Welcome to The Explainer. Today, we're basically becoming medical detectives. We're going to investigate a really strange and chronic infection that starts with something you wouldn't even think twice about, like a simple thorn prick, but can lead to a serious condition called Madura Foot.
So let's just jump right into that question, because it's the perfect place to start. This is our entry point into a disease called Mycetoma. You can think of it like a medical mystery that slowly, and I mean slowly, unfolds right under your skin.
All right, so what are we actually dealing with here? Well, mycetoma is an infection that kicks off after an injury, like that thorn prick we mentioned, gives microorganisms from the soil a free ride into your body. And this thing doesn't happen overnight. It's more like a slow, burning invasion of the skin and all the tissues just beneath it. And believe me, this is not a new disease. It was first written about way back in 1842 in a place called Madurai, India. And that's actually where the name Madura Foot comes from. Fast forward to today, and it's most common in this very specific part of the world that scientists call the Mycetoma belt, which, stretches right across the tropics. Okay, so any good investigation starts by gathering evidence, right? And when it comes to diagnosing mycetoma, there's a classic set of 3 clues that clinicians are always on the lookout for. This right here is what they call the clinical triad. It's the telltale sign of mycetoma. It all begins with clue number 1, a painless, firm lump that just kind of appears under the skin. Then, as the infection digs in, the second clue shows up. These little tunnels, or sinuses, start to form and eventually break through to the surface. And the final piece of evidence? The fluid that drains out of these sinuses has these tiny colored clumps in it called granules. When a doctor sees all 3 of those things together, well, mycetoma immediately becomes the prime suspect. So, we've gathered our initial evidence. Now we have to figure out who, or what, the culprit is. And this is where it gets really interesting, because there are 2 totally different types of microorganisms that could be behind all this. This is the crucial part. Mycetoma isn't just one thing. It's a condition that can be caused by either a fungus, which we call Eumycetoma, or a specific kind of branching bacteria, which gets the name Actinomycetoma. And telling these 2 apart, that is, without a doubt, the single most important step in this entire investigation.
And this chart just shows you perfectly how differently these 2 bad guys operate. The fungal version, Eumycetoma, it's usually slower, more contained, you get a single well-defined swelling, and just a few sinuses that show up late to the party. But the bacterial version, Actinomycetoma, that's much more aggressive. You'll see multiple swellings, tons of sinuses appearing early on. Even the discharge is different. Serious for fungal just means thin and watery, while purulent for bacterial means it's full of pus. And here's the kicker. Look at the bone. The fungus can cause osteosclerotic changes, making the bone denser, while the bacteria is often osteolytic. It literally eats away at the bone.
But the most telling piece of evidence, the real smoking gun if you will, is the granules themselves. Their color, their texture, it's like a calling card left at the crime scene, and often it points directly to the specific organism that's causing all the trouble.
So let's look at the evidence. If you find black granules, the investigation immediately focuses on a fungal culprit, usually a species called Madura mycetomatis. Now, if the granules are white, things get a little trickier. It could still be a fungus like an aspergillus or fusarium, but as we're about to see, that's not the only possibility. Because if those granules are white to yellow, or even this really distinctive pink to red color, our whole investigation pivots. Now we're looking at bacterial agents like Nocardia or Actinomadura. The color is just a massive clue. Okay, so a visual inspection gives us a really strong lead. But to be 100% sure of our suspect's identity, we've got to take the evidence to the lab for a full-on forensic analysis. And the lab has a pretty clear protocol. First, you collect the granules. Then, you literally crush them and look at them directly under a microscope. For an even deeper look, they'll analyze tissue samples. And for the final, definitive ID, they try to actually grow the organism in a culture. Now this is where the lab work gets definitive. What we're looking at here are the key findings. A KOH mount is a simple trick where you use potassium hydroxide to dissolve all the human cells, which makes it way easier to see any fungus. Under the scope, you'd see these relatively thick fungal hyphae. Those are the little branching filaments of the fungus. For bacteria, on the other hand, you use something called a gram stain, and that reveals much, much thinner bacilli. So it's not just a different stain, the size difference itself, thick for fungus, thin for bacteria, that is the microscopic smoking gun that confirms who the culprit is.
So with our culprits positively identified, we can finally move to close the case. And that means choosing the right weapon to fight this infection. And believe me, there are two completely different paths you have to take.
And this is exactly why this whole investigation matters so much. If the cause is fungal eumycetoma, you need antifungal drugs. If it's bacterial actinomycetoma, you need antibiotics. You can't mix and match. Giving a patient the wrong one just plain won't work.
So what do these treatments actually look like? Well, for the fungal Eumycetoma, doctors prescribe these long courses of powerful antifungal drugs like itraconazole. But for bacterial Actinomycetoma, they go straight to antibiotics. A really common and effective combo is known as the Welsh regimen. As you can see, there is absolutely zero overlap between the two treatment plans. So the huge takeaway here is this. All of that detective work, from looking at the swelling on the foot all the way to staining tiny granules in a lab, it is not just some academic exercise. It is the only way to make sure that a patient gets the specific medicine that can actually cure their infection. It makes all the difference.
You know, this whole thing started with just a simple injury and a little something from the soil. It really makes you wonder, with this unbelievably complex microscopic world just going on all around us, what other wild stories of infection are hiding just beneath the surface, just waiting for their chance to begin?